Sharing stories creates community. And real change usually happens where community happens. So this feels like an important evening. So thank you to Healthbeat Atlanta for devising and presenting this evening. We hope you enjoy it. A few house rules and guidelines. Phone silent. Respect the speakers by listening and staying put if you can. The bathrooms, the restrooms are just out down the hallway there if you need to leave for the restrooms. We will take breaks for food and drink orders. You know what to do. Thank you so much. We are really grateful to Manny's for hosting us here and for taking care of us. And I think they deserve at least this first round of applause. Thanks to Manny's. Before we kick off, I need to introduce Charlene Pesenti, Healthbeat's editor-in-chief, who will set the stage for tonight's event. Charlene.
Well, I'm going to move this, and then when Johnny speaks later at like 7 feet tall, he's going to have to move it again. But thanks to everybody for coming out tonight. This is Healthbeat's first ever live storytelling event. So thank you, Atlanta. We got a really amazing response to this project, and I want to thank everyone who submitted a story. It was really hard to choose the ones for the stage, but we're going to be able to publish so many more online as well. So keep checking Healthbeat for those stories. We're probably going to start running those next week. I want to thank the Georgia Health Initiative for sponsoring tonight's event. So clap for them. You'll hear a little bit from them a little bit later too. Shout out to Healthbeat's Atlanta reporter, Rebecca Grapevine. Wait, Rebecca. Rebecca worked really hard. I think everyone in this room already knows her, but you're going to hear a little bit from her as well. You'll see we're capturing video of tonight's show. We're going to be posting that in the days to come. If you catch any snippets tonight and you put anything on social, please tag us. We are really looking to amplify these stories way beyond this room, so we're going to be publishing them on all our platforms in video and the text. So spread the word as soon as you see those come out. We really appreciate that. As Rob was saying, storytelling brings people together. And actually, as many of you may know, scientific research shows that storytelling helps science feel less distant. And hearing about the lived experiences of our neighbors can help us understand the big picture, from the whole wide world to our backyards here in Atlanta. Healthbeat's tagline is Public Health Explained, and that's really what we're here to do, to connect those dots, to tell people what public health is and who public health is. It's the people in this room working hard every day for the health of the entire community. So tonight you're going to hear stories that connect those dots, that show us why public health matters to everyone. These stories need to be told. There's power in those stories, and we want to share them with everyone that we can. That's what Healthbeat is here to do. As we're entering our second year, and there's so much more to come. So please stay tuned to Rebecca's newsletter. Check out healthbeat.org, and keep on supporting. We really appreciate it. Thank you.
Thank you, Charlene. Dr. Alawade Oladele is the supervising physician and laboratory director for infectious diseases and refugee health at DeKalb Public Health, following decades in global public health. He has degrees from the Morehouse School of Medicine and the Rollins School of Public Health at Emory University. Tonight, he takes us to Haiti for an aha moment on the beauty of community and supporting one another. Dr. O.
Good evening. Good evening. Shout out to Charlene, Rebecca, and the Healthbeats family. Join you today, but really I'd like for you to take a minute to think about everything that's going on in the world today and what differences you all could make. So the title of my piece is Ikigai to Ubuntu. Ever heard of Ikigai? Ubuntu? Okay. So this is a story of impact and connection. In the tapestry of life, there are moments that stand out like vibrant threads, weaving together experiences that shape our understanding of purpose and community. One such moment for me was the day that I discovered the profound connection between the Japanese concept of ikigai, in other words, that reason for being, and the African philosophy of Ubuntu, which emphasizes our shared community. This realization came to me in a small, unassuming community health center where a simple act of kindness resulted in a chance encounter that transformed my perspective on the impact of my work. It was a warm, muggy afternoon on the outskirts of Haiti, similar to the muggy afternoons in Lagos where I grew up. I was at a local community health center, a place that served as a refuge of hope for many in the surrounding neighborhood. As I entered the compound, I was greeted by the warm smiles of children playing and the gentle humming of conversations among the countless adults who were present. You see, I had been involved in various community projects over the years and around the world, but this day felt different. It had been a few years since Haiti experienced that 7.0 magnitude earthquake that left tens of thousands dead and millions homeless. I was there to help organize the health fair, but little did I know that I was about to experience a pivotal moment in my life. As I sorted through boxes of medical supplies that we had acquired from a group here in Atlanta, MedShare International, I noticed an elderly woman sitting alone at a table. Her hands were trembling slightly as she sorted through boxes of food. Her name was Mama Gerline, a widow who had lived in the community for decades. I approached her and offered a smile and a helping hand. We began to chat. And she shared stories of her late husband and her late children, all lost in the 2010 earthquake. We talked about the challenges she faced living on rations on a day-to-day basis, despite having extraordinarily little left to her name. She was determined to do her part to help rebuild her torn nation. She believed that her life had been spared during the earthquake so that she could be a messenger of hope and change. She did not have any sources of funding like the big NGOs that were all over Haiti at that point in time. But you know what? She had a heart of gold and a determination of steel. As she spoke, I felt a deep sense of empathy wash over me. Here was a woman whose life was filled with love and loss, yet she radiated resilience and hope. I asked what we could do differently for her and the community, and she stated, "You know what? Don't worry about me. Instead, focus on the youth, for they represent tomorrow." You know, she stated that children represent the heartbeat of a broken community. And if that heart failed, the community itself would cease to flourish. In that moment, I realized but that my work was not just about organizing health fairs and collecting and distributing medical equipment and supplies. It was about connecting with people and truly understanding their stories and recognizing the impact of our collective efforts in the bid to transform the community. Mama Gerline's gratitude for the small act of kindness we offered was palpable. She expressed how the community center had become a lifeline for her and many, many others, a place where she felt valued and cared for. And you know what? It struck me. This was the very essence of Ikigai, finding purpose in serving others and contributing to that greater good. As our conversations deepened, Mama Gerline introduced me to what I then realized was the concept of Ubuntu. She explained a phrase, "I am because we are." It encapsulates the idea that our identities are intertwined with those of others. This philosophy resonated with me, illuminating a path forward that I had not previously considered. I began to see how my work could extend beyond the individual acts to foster a sense of community and belonging. That day, I left the community center with a renewed sense of purpose. What we were doing was simply not enough. The children in the community needed to go to school in order to champion the cause of tomorrow. But to do that, they needed food, nourishment. They needed a safe environment to live, learn, and play in. So our group of graduate students from schools all around the metro area and volunteers adopted a Creole term on that day, "Nu Kapab," simply meaning we can. And it became our call to action and our rallying cry. I understood then that my role was not merely to aid, but to cultivate relationships and to create an environment where everybody felt seen, heard, and truly respected. That ripple effect of a small act of care and simply listening could lead to the transformation of lives. Just as it had for Madame Gerline, I realized that when we invest in one another, we build a strong and more resilient community. In the weeks, months, and in fact, years that followed, I took this newfound understanding to heart. I began to engage more deeply with the people that we served. I truly learned to listen to their stories and learn about their needs. We organized student movements. We not only provided outreach and resources, but we also fostered connections among the community members by engaging the community and performing extensive community needs assessments. I witnessed firsthand how small initiatives created a sense of belonging and empowerment. People began to come from all over Haiti to share their knowledge, their skills, and their many talents, forming a network of support that transcended the individual struggles. This breakthrough that I experienced on that day was not just a personal revelation. It was truly a call to action. I understood that my work could be a catalyst for change and a means to uplift others and create a healthier and more compassionate society. The principles of Ikigai and Ubuntu became my guiding light in my journey, reminding me that true fulfillment comes from serving others and truly, truly recognizing our shared humanity. So, reflecting on that pivotal moment, I am truly blessed and grateful to have had the opportunity to connect with Madame Gerline and many others who have enriched my life. Their stories have taught me that every small act of kindness has the potential to create ripples of change and transformation. I have come to appreciate the beauty of community where we can support one another and thrive collectively. And in conclusion, my journey from Ikigai to Ubuntu has simply been transformative. It has illuminated a path forward, one that emphasizes the importance of connection, empathy, and shared purpose. So as I continue to navigate my work and my life, I carry with me the lessons that I learned on that muggy afternoon in Port-au-Prince, Haiti. A reminder that we are all interconnected and that our actions, no matter how small, can have a lasting impact on the world around us. Thank you all very much for taking this journey with me.
Dr. Alawode Oladele, thank you so much. Before we continue, can I ask if you have a spare seat near you, could you put your hand up so that some people who are trying to come in and sit can perhaps join you? There's one seat down here. There's another one down here if we need. There's one here. Yep. Come on down, the price is right. So they tell me. I'm going to introduce now Joanna King, the Vice President of Strategic Communications of the Georgia Health Initiative and the sponsor of tonight's event. Joanna King.
Hi everyone, it's so lovely to be sharing space with everyone. As mentioned, I'm Joanne Kang and I'm the Vice President of Strategic Communications with Georgia Health Initiative. I am one of a handful of initiative team members who are here. We're all the motley crew that's in the back, so I'm going to ask for them to wave their hands so that you can spot them as well. But for those who may not be familiar with who we are a nonpartisan, nonprofit private foundation, and our vision is working toward a Georgia where all people have the opportunity to attain their fullest potential for health. And with such an easy goal to attain, of course, we don't work in isolation, but we have the privilege of working across partners in the nonprofit and other sectors. And it's such an honor for us to be able to sponsor today's event. I think it's so lovely to be in this room for an evening full of ahas. And we definitely, as a team, appreciate the critical role of public and community health workers. In addition to that, we so appreciate the importance, the practice, and the art of storytelling, because we don't think that there's any substitution for hearing about the real world experiences and the personal lives that are being touched. And so when we were reached out with the opportunity to sponsor, it was a very easy yes. Hopefully everybody has received a little friendship pin. If not, they're in the back. It has our organizational logo, and the wonderful Miss Naomi was passing out these cards that ask the question, what does a healthy Georgia mean to you? Whenever we have the opportunity to meet with individuals across the state, we always ask this question, because we know that it's going to mean something different for every single individual. And we love hearing the reflections, the aspirations, and the hopes that each of you have, and that just motivates us and helps to inform our efforts in working toward a healthier state. So I am very happy to give the mic over to the next storyteller, but before I do, I just want to say a big thank you to our partners at Healthbeat, not only for putting together such an innovative and creative night of ahas, but also for your ongoing storytelling through your reporting on the issues that matter. We also want to say thank you and appreciate everybody who is willing to share their personal stories today, and of course for everybody who took the time to be here. In doing so, we know that you recognize the very critical importance of being in community and being in conversation. So thank you.
Thanks, Joanne. Sarah Blake, PhD, is an associate professor at Emory University's Rollins School of Public Health and serves as director of Emory's Maternal and Child Health Center of Excellence. A health services researcher, Dr. Blake is married, a mother of 2 sons, and is an Atlanta native. Like her mother, she was born down the street at Georgia Baptist Hospital, renamed years later as the Atlanta Medical Center. This hospital recently closed, among numerous labor and delivery hospitals that have closed in Georgia. Tonight, she shares the aha moment that led her down this career path, breastfeeding by candlelight.
Thanks everybody for being here. I really appreciate you coming here on a Monday night. I also want to echo thanks to Healthbeat, Georgia Health Initiative, for creating this event, and I can't think of a more important time to celebrate public health. I also wanted just to take a quick moment to thank Rob Spar. He's our Public Relations Director at the Rollins School of Public Health, and he encouraged me to tell my story, nudged me a little bit to put this story down on paper. So here you go, Breastfeeding by Candlelight. While this story could be called How I Almost Named My Son After a Hurricane, instead it tells the story of what inspired me to spend my public health career addressing vulnerabilities in maternal and child health. On September 16th, 2004, 2 days after delivering my first child, I was discharged from an Atlanta area hospital into the aftermath of Hurricane Ivan. Now, in my postpartum haze, I had no idea what havoc this storm was about to unleash in our lives. At that time, Hurricane Ivan was one of the most devastating natural disasters ever to hit Georgia, producing widespread tornadoes, power outages, and tornadoes throughout the coast of Georgia. So what should have been a 20-minute ride home took 2.5 hours. At one point, my husband over here pulled off the side of the highway so that I could nurse my newborn son in the car. When we arrived home, we learned that we had no power and, worst of all, no air conditioning. And as you know, in Atlanta, in early fall can cause unrelentless humidity. So the next part is a little TMI, but I thought it was important to share that my newborn son at birth weighed 10 pounds, 14 ounces. Yeah. So just 2 days earlier, I had delivered an almost 11-pound baby. Yeah, my first. So what this meant was that my son was hungry all the time. So as the downpour continued, amidst the darkness and the heat, we hurried to get settled into the house. So for the first hour or so, I tried my best to breastfeed by candlelight, but through tears, sweat, and frustration, I just could not function. So I asked my husband, pleaded, maybe demanded, help to get out of the house. And luckily, we were able to check into a hotel where safety and electricity comforted us through our first night out of the hospital. This aha moment of breastfeeding by candlelight turned into my career, inspired to address disparities in maternal and child health. Unfortunately, being a new mother, going through the nightmare of a natural disaster is not a unique or an unusual experience, but it is in fact a dangerous one. History has shown that pregnant and postpartum women are particularly vulnerable during emergencies. They have functional needs that require additional social and healthcare-related support, including prenatal and postpartum care and lactation support. Evidence has demonstrated that emergencies can cause heightened stress among this population, often leading to adverse maternal and infant health outcomes, including miscarriage, premature delivery, low birth weight, and mental health challenges. These were the experiences of many women who were pregnant or delivered during several natural disasters, including Hurricane Katrina in Louisiana, Hurricane Harvey in Texas, and most recently Hurricane Helene in North Carolina. And we can only imagine what we will learn from our Hurricane Melissa that just happened in Jamaica a week ago. There are other types of emergencies that mothers experience that are both harmful and preventable. For instance, extreme heat during pregnancy has been shown to increase women's risk for severe maternal morbidity and adverse infant health outcomes. The COVID-19 pandemic shed light on the importance of maternal immunization to protect women from complications of infectious disease during and after pregnancy. Even human-caused disasters, such as those caused by bioterrorism, think 9/11, have been shown to have long-lasting effects on mothers and their infants. Through my work, I partner with public health agencies and community organizations to create strategies that improve maternal and child health, emergency preparedness planning, and response. Just recently, I worked with my collaborators from the Georgia Department of Public Health, the Morehouse School of Medicine Center for Maternal Health Equity, and Healthy Mothers, Healthy Babies of Georgia to complete Project Prepare. Project Prepare was a CDC-funded study of preparedness and readiness for emergency planning among pregnant and postpartum women in Georgia. Our findings reveal that mothers in Georgia are often disconnected from their healthcare providers for essential information and support before, during, and after emergencies. They also lack essential financial and social services during emergencies that are needed to ensure healthy outcomes. These findings are especially important in Georgia, where women experience among the highest rates of maternal mortality. As both a women's health advocate, a health services researcher, especially as a mother, it is my mission to address the vulnerabilities that women experience, particularly during the perinatal period. It is both my purpose and a call to action that I take on both willingly and in these challenging times with unwavering resolve. So I dedicate the story to my firstborn son, Will, or Ivan, as he is fondly and sometimes called. So thank you very much for your time.
Our next speaker is Rebecca Grapevine, who is a Healthbeat reporter. When I asked Rebecca how I could introduce her, she said, well, I'm an Atlanta native. I said, how long have you been a journalist? 5 years, she said. And that's all she would tell me. Her story will tell you everything else you need to know. Ladies and gentlemen, Rebecca Grapevine, Healthbeat reporter.
Thank you all for being here tonight and for fielding my many phone calls and emails over the past year since we launched Healthbeat. This is a story about how I became a reporter. In 2016 and 2017, I worked at a hospital and community health program in eastern rural India. That experience revolutionized my view of what healthcare can be. Everything in our system was geared to serve the patients. Signs over different offices and departments and our paperwork all had pictograms to serve our largely illiterate and semi-literate patient population. This system proved so effective that many of our village and maternal health workers never learned to read, but could still successfully complete their work shepherding their patients through our medical system. We economized on everything as well. Everything from using mosquito nets to do hernia repairs. There's actually been scientific studies about the efficacy of this. And having teams who washed our gloves with dried bleach in washing machines so that we didn't have to keep purchasing disposable gloves over and over. So needless to say, we didn't have much, and it wasn't a perfect system, but what we did have was care, respect, and compassion, all built into a community health system designed to serve the community around it. When I came back to Atlanta, I worked in hospital emergency rooms, a hospital that has been mentioned already tonight, in fact, and is no longer here. Here in this hospital, we had state-of-the-art equipment, highly trained and paid staff, air conditioning, and gloves galore, so much that people would just toss them on the floor. But something felt different to me. Patients and doctors all spoke English, but they talked right past one another. Doctors were scolded for taking too long with patients. Psychiatric patients and other patients as well lingered in our rooms and our hallways for days because we couldn't find a place to send them. Emergency room was no place for them, but they had no place to go. Worst of all, we were all rowing in different directions. The doctors answered to one authority. The nurses answered to a different authority. There were social workers and chaplains who appeared and then disappeared, and nobody paid attention to the environmental services team who worked so hard to turn over the rooms so that we could see more patients. I was disillusioned, really, that my hometown, a public health capital, couldn't provide the kind of compassionate care that I had seen in India. Yes, our patients were sick, but so was our system. For more than a year, I took all this in and bottled up my emotions, mostly. I shared a lot of them with my mother, though. She took the brunt of it. Thanks, Mom. It was a lot of anger, sadness, and disillusionment. Finally, I had my own aha moment. I put down that bottle of bitter emotions, and I picked up my pen, pledging to write about what I knew. That was more than 5 years ago, and while I can't claim to have single-handedly fixed our healthcare system here in Atlanta, I am proud to be here, still writing about health in my hometown, learning from all of you every day, thank you again, and carrying with me and channeling the compassion and can-do spirit that I learned thousands of miles away in rural India. Thank you.
Thanks, Rebecca. Honore V. Holmes is a Metro Atlanta firefighter. I feel like that's all I need to say. A Metro Atlanta firefighter and an award-winning journalist who has been honored by the state of Georgia for excellence in trauma care. He works to build and strengthen community, amplifying resilience and reimagining American heroism. Tonight, he shares the story of how answering a 911 call gave him a revelation about stigma, family, and the true meaning of care. Honore Holmes.
Thank you all so much for being here. Thank you for the sponsors. You can't do anything without money, right? So we always thank those people. And thank you to Sheila Poole, who kind of found me. So basically, to set this up, I was a firefighter, but of course, you know, the pay, they take so much out with insurance and pension and this, that, the third. We need a part-time job if you want to live, you know what I'm saying, if you want to have some fun and not merely exist and run calls. So I picked up a job at Grady as riding as an EMT. So this is what that shift, the call that changed my shift and my life. Grady Unit 695, respond to Metropolitan Parkway. Now when it comes to emergency medicine, unpredictability is part of the job. You never know if the next call will be a heart attack, a car crash, or a cry for help that no one else really knows how to answer. That morning, the radio crackled with a call that seemed routine enough. A 52-year-old female off medication, flashing drivers, walking in and out of traffic. It was my third hour into a 13-hour shift at Grady, one of the largest public hospitals in the South. My partner and I, we had a system. He drove, and I handled the behavioral emergencies because people get antsy about babies, psych patients, and the like. So you figure out how you're going to divide the work and you do it. That division wasn't random, like I was mentioning. It was personal. My biological mother had lived with schizophrenia until her death at age 42. In the 1980s, no one spoke openly about depression, psychosis, stress. People just said my mother was crazy. I still remember her walking down Albany Avenue in Hartford, Connecticut, wearing a pink tutu and a white leotard, smiling at strangers who didn't understand. I was too young to see she wasn't dangerous. She was sick, and society and family didn't know quite what to do with her. On the way to Metropolitan Parkway, all I could think about is, please don't let this woman be wearing a tutu. Right. Meeting Miss Mary. When we arrived, Miss Mary stood near a weathered Cutlass Supreme, her yellow sundress dancing in the breeze. She was poised, articulate, and surprisingly self-aware. My daughter's getting on my nerves, she told us. I need to go to Georgia Regional for 30 days. Her honesty made me smile. I invited her into the back of the ambulance where it was cooler. As I checked her pulse, she explained she had schizophrenia, high blood pressure, and was borderline diabetic. She stopped taking her meds because it made her feel off balance. She didn't like feeling like a vegetable. Something I'd heard before, and something I understood. Then, with blunt curiosity that often comes with familiarity, she looked me up and down and asked a question about my sexuality. One that could have stung in another setting, but her tone wasn't cruel. It was matter of fact. Before I could respond, she added, "My grandson's gay too, and I love him. When we walk down the street, he holds my hand. Don't let them folks bother you, baby. You just be yourself." The tension in that ambulance dissolved into something like grace, a mirror in the back of the ambulance. Ms. Mary didn't know she was speaking to someone who had spent a lifetime wrestling with identity. I'd always been aware of my otherness, the way I walked, talked, carried myself. At 6, a cousin once asked, "Why do you walk like that? You walk like a girl." Later, my grandmother, who I love deeply, told me, "Baby, you got a spirit inside you. One I could pray to God to take away." I didn't understand what spirit was, only that it seemed to make people uneasy. Her words filled me with confusion. How could I pray away something that felt so natural, something that I was, something that was me? Years later, in the back of the ambulance, Ms. Mary unknowingly answered my grandmother's question. She told me without apology or hesitation to live in my truth. Her message, "You just be yourself, baby," felt like permission I'd been waiting my whole life to receive. Beyond the emergency. After that call, I couldn't stop thinking about the deeper patterns I saw every day. So many people like Ms. Mary were cycling in and out of emergency rooms, never getting the long-term care they needed. So many families like mine were left to cope alone. Too many conversations about health stopped at the body and ignored the mind and the structural issues that shape both. Being an EMT taught me that to treat the crisis in front of me. But I began to realize the bigger work lay in preventing the crisis before it started. That's when I found my way to public health. Public health asked the questions that had been haunting me all along. Why do people like Ms. Mary fall through the cracks? Why don't families like mine get the help they deserve? Why do stigma and silence still have so much power over who gets well and who doesn't? I wanted to do more than respond to emergencies. I wanted to change the conditions that caused them. You got work to do. Months later, I saw Ms. Mary again. I was sitting at a red light in Atlanta's West End, and when I stopped, her black miniskirt, red sandals, and that same confident stride caught my eye. I rolled down my window, waved, and called out to her. She turned, met my eyes, bent down with a knowing smile. "Don't be late, baby, you got work to do." Turned around and kept walking. Her words have stayed with me because she was absolutely right. I do have work to do. Work that honors my mother. Work that lifts people like Ms. Mary. Work that challenges the systems that silence the vulnerable and stigmatize the misunderstood. That single 911 call didn't just change a shift, it changed my purpose. That's why I chose public health and firefighting, not for the prestige, but for the people, for those who walk through the world labeled as problems when really they're prophets, reminding us all what care should look like. Thank you.
Brandon Kennemer is an associate director for informatics focused on data science, surveillance, and communications at the CDC. He was inspired by civil service at an early age, lives in Atlanta, and continues to commit his time and energy to the public while seeking alternative avenues for work. Prior to the CDC, he worked in psychology, behavioral health, and nursing care. Tonight he's sharing a story of 3 aha moments in science and health, going all the way back to his childhood. Brandon Kennemer.
Thank you so much. Many of you know, as public servants, we're not used to often standing in the spotlight. So I just want to appreciate and really acknowledge everyone who stood up here tonight for their stories. They've impacted me. I'm sure they're impacting many others and those dedicated in service. So I also want to just acknowledge my appreciation for Healthbeat, Manuel's Tavern, and Georgia Health Initiative for sponsoring us tonight, for our stories. Once public health, always public health. So I know I'm surrounded by familiar hearts, a collective family, and one that reaches deeply into the soil to preserve the roots of the work we've done. I was a career scientist at the CDC, Centers for Disease Control and Prevention, for 9 years, and a public health professional for over 20 years. I had my aha moments over many of those, so I'll tell you just a few of them. First aha moment was when I was 10 years old. I was sitting on the couch with my grandmother, watching a movie, as we did every time I visited. I saw helicopters, people in uniform, a lot of action. And the thing that stood out to me most, that I was curious about, was what was a BSL? I saw BSL 1, BSL 2, BSL 3, and so on. And many of you probably know that was the entry to the movie Outbreak. If you don't know, BSL stands for biosafety level, 1 being the lowest. I was a curious kid, always questioning and discovering answers to the world. You can imagine how much my parents must have loved me. Some may have watched that movie and thought that they wanted to be Dustin Hoffman, the virologist investigating the entire outbreak. I always wanted to be Rene Russo. Why? We know. But because she was the one who practiced public health and science in the movie the most. My aha was learning that I didn't want to be the person who knew how government and knowledge was controlled and dispensed, but rather the person who was on the ground with the people it directed and affected. Rene Russo embodied the sacrifices and the leadership that changed the entire outcome of the film. At 10 years old, I wrote an essay, if you can even call it that, about how I wanted to be a scientist, and it propelled me on a linear track of achieving that goal. My second aha was actually becoming that scientist. I realized that I didn't actually know how much I needed to actually do the job. I was thankful for other career scientists, mentors who guided me through. If you would have told me that it would have taken me 10 years to understand the science once I infiltrated that organization and agency, and then another decade to understand how I fit into it, I don't know that I would have continued on that path. So I had another aha, that we don't have to know it all. That part of public health is constantly learning and appreciating that so much of the lessons that come to us are things that come from others. My third was learning that as a civil servant and one who dedicated their life to saving others, that I would never have given up or halted in my efforts, the job is never ending. And so to relate back to my first movie, Outbreak, my second was the never-ending story. Many of us can likely relate to this, right? Who didn't want a Falcor in their life? But the impact of that movie and a scene with a horse, all tracks, is the swamp of sadness. We remember that scene because it is also the sensation of leaving your most beloved thing behind. That, in many ways, is what it feels like to be dismissed from the duty of CDC and public health. With all that said, I continue to question, to be curious, to investigate, analyze, and report on my life, assessing others who need information, and to support the wider communities that rely on us and our strongest efforts. Because who am I without everyone else? And with the sadness of our professions being attacked, we persevere. May we all belong, protect, and continue our fierce empowerment of public health in our efforts. Wherever your story lies, know that it is supported in light and love. Thank you. With solidarity, may we create healthy communities always. Thank you.
Brandon Kennemer. Thank you, Brandon. Rachel Galloway is the British Consul General, my British Consul General, to the southeast of the United States. She arrived in July 2022, having previously served as the UK's ambassador to the Republic of North Macedonia, where she played a pivotal role in strengthening diplomatic relations in the region, including the country's accession to NATO. Her career spans various positions, from working in Brussels at the EU to leading a team working on Darfur policy, to a posting in Helmand province in Afghanistan, to a stint in the British Embassy in Washington. Rachel's married to Tom and has 2 children in Atlanta Public Schools and a cat called Rollo. Tonight she shares her aha moment from the heart of the Balkans and the door that changed everything. Rachel Galloway.
Good evening. Thank you for having me here tonight. So I'm going to talk a little about doors. So it's the expression, you just need someone to open the door, and then you can make it happen. So in my last job, I was in North Macedonia, which is in the Balkans. And while I was there, the National Institute of Public Health released some statistics about menstrual poverty and the fact that in the country, 90% of girls who lived in rural areas and 75% of girls who lived in urban areas were missing school when they had their periods, which is obviously a startling percentage and having a massive impact on the education of girls. So we decided, what could we do about this? We looked into it, we set up a small project, a very, very small amount of money, and we discovered essentially that the reason why girls weren't going to school was not just that they didn't have access to sanitary products, but that in some of the schools, the toilets didn't even have doors. So, put a small amount of money aside, went into with one regional government, went into some schools, fixed up the toilets, and provided some sanitary products. But the main thing we did was worked with journalists to publicise what we were doing and what the problem was. And as a result of that, 3 things happened. First of all, the World Bank came in with funding and renovated the toilets in all elementary schools in the country. The second thing was the government decided to put sanitary products into the high schools. And then the third thing was the government decided to lift all tax on sanitary products in the country. So, tiny, tiny project. tiny project, but we opened a door and we had a huge impact. Cut to a year later, it's 2020. Don't need to tell people in this room much about 2020. But one of the things from talking to people was another healthcare desert we were coming across was around access to gynecological care. And it was particularly bad, once again, in rural communities where people were locked in their homes, women were not able to get out of them, and in some cases what was behind those doors was really not very safe. So we worked with a health organisation and they retrofitted an ambulance and made it into a mobile gynecological clinic. And it went around the country and it got into places where sometimes women had probably really never seen this sort of healthcare, Roma communities. So great story, great success. Once again, we opened a door, we got people into a clinic. But the problem was, our sort of aha moment is this is quite short term. This isn't the sort of public health work that the people in this room are trying to do. And in part, the reason why it's so short term is because the doctors and nurses who are volunteering their time to do this don't know the stories of the women they're helping. They don't know the community. They aren't doing what you have all been talking about tonight. So what we've been thinking about even now going forward is what tools can we give to healthcare professionals? How can we help them open doors? And one of the things that we've been working on, and I know people are going to be slightly doubtful about what I say next, is we've been talking about what tools are currently available. What's one of the ones that gets lots of splashy time at the moment is AI, right? So the UK, we've been working with the US, we've set up a technology partnership to look at how we can use AI in healthcare, not to replace doctors and nurses, but to give them the tools, to give them the information, so when that we do go into these communities, we already know the stories. We already have the information that we need to help people. And that's what we've been thinking about. That's my aha moment, is how do we open more doors? And it's why it was so exciting to be invited to this event tonight by Healthbeat and the Georgia Health Initiative, and to see your stories and what doors we're opening together. So thank you very much for having me here.
Aliki Papas-Weekland has over 25 years' experience in social services and public health. She currently serves as an Associate Director in the CDC's Office of Readiness and Response. Among her degrees is an MPH from Emory's Rollins School of Public Health. She lives in Atlanta with her spouse and Boston Terrier named Alfie. No friend to Rollo. Tonight she takes us back to New York City, where as a social worker, early in her career, she had an aha moment that shaped her path forward and remains in her thoughts to this day. Aliki Papas-Weekland.
Oh, good, the light is good. I don't need the specs. Really excited to be here this evening. Really happy to be at Manuel's, which historically is a place where people come together and have conversation, and I think ideas are born. Georgia Health Initiative, thank you so much for sponsoring this. And Healthbeat, I'm so excited that you brought an opportunity for all of us to be inspired by one another. And a special shout out to my friend Sarah Foster, who encouraged me to submit. Early in my career, I was a social worker in Manhattan, helping older adults navigate life's challenges. I had studied social service administrative practice at school, and I wanted to make big systems better for people. But to do this, I knew that I first needed to sort of live inside one of these systems to understand it from the inside out. The walk-in center where I worked was a converted storefront, a cramped space with 9 desks and little room for privacy, but it was full of purpose and always teeming with people. My desk was just 10 feet from the door, with a waiting area tucked in between. And it was spitting distance from the receptionist, who would put calls on hold, and then she'd call out like we were fields apart from each other. "You've got a call on line 3!" Many of the people that I served shared similar struggles: loneliness, fading social connections, and confusion with the systems meant to help them. It was a humble, imperfect place, but it taught me something really important, especially at the start of my career. We had scarce resources. There were no frills. I mean, the bathroom door hit the bookkeeper's desk every single time. And there were so many challenges, constant challenges. But every day we showed up to help people figure things out. One day in October, a little over a year in, something happened. I emerged from the stifling heat of the subway and felt the crisp fall air snap into my lungs. As I walked with the familiar waking rhythm of the city swirling around me, I thought of fall in New England, when green leaves always gave way to brilliant reds and golds that were swept away by a gust of wind, only to gently fall and settle as a waiting pile that would elicit shrieks of joy from bounding children. That cycle was and is still a simple, natural, predictable one where each action yields another and every aspect of life is connected. That October morning, my mind drifting with the leaves, I turned the corner to my workplace and I stopped short. There, perched on the stoop in front of me, was James. Head tucked, his body was curled in on itself, he was rocking slightly and oozing sadness. James had been coming to the center for about 6 months. He had lost his partner of 20 years to complications from AIDS. And though he came in first to help with a heating issue, he was seeking some help, he regularly returned with small but compounding needs, each one seeming too big to handle, too confusing to navigate, and too much to deal with. With each visit, James talked, and I listened to his stories of love, loss, and grief. I could see he had a growing sadness that was pulling him down like quicksand, slow and deliberate in its lasting grip. I saw it happening, but I struggled. I struggled with what to do to fix it. When I saw him that morning, wound tight with despair, I ushered him inside and I sat with him. He cried. I listened. When his sobs finally slowed, he began to speak. The words that he whispered that day have stayed with me ever since. James told me he had woken that morning in the stillness of his life, and he thought of suicide. He dressed and he walked to the stairwell leading to his building's roof, and he stood there staring upward. He put his first step, and he thought, I can go up to the roof and jump, or I can go and talk to a leaky. There were mornings after that day when I would arrive at work wondering, will today be the day that James chooses the roof? I think often of the simple power of that lesson for me. It was when my job became my purpose. When I realized I would carry an enormity and an intimacy in service to others. When I realized that the smallest human connection could shift the course of a life. Now, years later, and after many more years in public health service, I reflect on that time, on the tiny office, scarce resources, and the endless challenges. I'm reminded that the most powerful system of all is not born from policy or organizational design or quick fixes. It is in the simple, natural, predictable actions. It lives in the smallest moments, the listening without fixing, the quiet power to make a difference, one person at a time. It is the shared joy of jumping in a pile of leaves and shrieking with glee. Thank you.
I'm very happy to introduce to you Johnny Smith. Johnny Smith is a certified addiction counselor and substance abuse case manager at Mercy Care, where he helps guide others through the same journey he once walked. A former top-ranked basketball player in Georgia and professional athlete overseas, Johnny's life took a dramatic turn due to addiction. After years of struggle, he found recovery at the Salvation Army, where he now also serves as a part-time chaplain. Clean since February 19, 2016, coming up on 10 years. Johnny brings lived experience, deep empathy, and a powerful voice to his work. Tonight, he shares an aha moment about second chances. Johnny Smith.
Good evening. I would like to thank Healthbeat and Charlene for inviting me out. I would like to thank my supervisor at Mercy Care, Michelle, our top-notch social media team of Mercy Care, Irvin and Rochelle, and my favorite baby mama, Nicole. I used to have a mind that told me that it was okay to smoke weed, drink alcohol, smoke crack, do lines of cocaine. On top of my mind telling me that, my body said, I'm gonna make sure your hangovers are not as intense. I'm gonna make sure you don't develop no high blood pressure, no diabetes. And once I hear that, I can keep on drugging and drinking. Now I'm pretty much screwed. But once I began to understand this, the nature of this disease and why I was so powerless over it, now I'm desperately in need of searching for a solution. Admitting that I was powerless over drugs and alcohol was the hardest damn thing I ever had to do. And that was harder than being an athlete. The title of my aha moment is The Last Time I Saw Him. I've been an addiction counselor for several years now. And every now and then, I have a client I can't forget about. And this one really stuck with me. I had a client who was referred to me from an outside agency here in Atlanta. And he was homeless, strong opioid, fentanyl addiction. He was getting his Suboxone through 10 Park Place, Fulton County Health Department. And every 2-3 weeks, I would have to let him go out to get his Suboxone. We kept it on the lock and key, 2 keys, 2 locks. And when the clients come to treatment, they come with at least a 30-day supply of HIV medication, blood pressure medication, whatever it be. So in the morning time, we give them their medication. We log it and make sure that they are taking it appropriately. This guy, he was from South Georgia. Used to climb trees for a living as a tree cutter. He had a whole Facebook page full of pictures of him way up in them trees, cutting down branches. but addiction does not care how strong you are. Word got back to me that he was selling his Suboxone or maybe just overusing it. Either way, I still had to let him go at least every 2 to 3 weeks to get his refill. And then one day in my office, I'm sitting at my desk with him and another veteran, and the guy is slumped over in the chair. He goes to snoring. I hear him snoring, but it hasn't quite hit me yet. And I tell the veteran, I say, hey, nudge him, let's wake him up. Still hadn't quite hit me yet. The veteran nudged him, and he proceeds to slide out the chair. I'm like, Jesus, he's going into a cardiac arrest. I jump into action, start performing CPR. If you've never done CPR, that's a workout. I'm able to dial 911 from the desk office speakerphone. Me and the veteran, we are rotating compressions on the guy. I'm yelling down the hall at the shelter for somebody bring me the defibrillator. No clients, no staff there to hear me. Finally, the ambulance arrives. The guy is on the stretcher, with all them heart monitors on his chest. And the first thing he says to me, Mr. Smith, you saved my life, and I'm never doing dope again. I believed him, wanted to believe him. But maybe 10 days later, he's back. High as a kite, shirt off, fall, wintertime, causing a commotion in the parking lot. I go outside, talk to him, and I say, what about what you told me? Remember that part you told me that I saved your life? You never doing dope again? He looked me eye to eye. He said, I don't remember. That was the last time I saw him. And here's the thing. This isn't rare, but addiction is a disease. It's not a choice. It's not a moral failure. It's a cycle. And sometimes, when you save someone's life, they don't remember it. Or maybe they're just not ready. Or maybe they're just too deep into their addiction. But at the end of the day, we keep on showing up. We keep on showing up because every person who walks through our doors deserves another chance. That's my aha moment. Thank you.
Johnny Smith, thank you. Catherine Grace Singleton is a genetics and molecular biology PhD candidate at Emory University. She's from Sumter, South Carolina, and did her undergraduate degree in research at Clemson University. After completion of a PhD, Catherine hopes to complete an accredited laboratory genetics and genomics fellowship program to continue research in a clinical setting. Catherine lives in Atlanta with her cat Olive and Olive's friend, the dog Eloise, No friend to Alfie or Rollo. Tonight, Catherine shares a very personal aha moment that led to her career in science. Catherine Grace Singleton.
Hi. Thank you for inviting me here tonight. This is very exciting for me. I feel like my story might be a little bit of a departure from some of the others that we've heard this evening, just because I think a lot of the people we've heard from, their stories have stemmed from how they have helped others. But in this case, I was the patient, so. Days after my 18th birthday, I had a seizure in a lecture hall of 300 people. My introduction to college life. And Clemson University, which involved an ER trip and a big unanswered question. What caused the seizure? What was going on? Afterwards, my health began to decline pretty steadily. My heart was constantly racing out of control, and I would get dizzy and start sweating profusely, occasionally passing out. I was severely fatigued, and my body ached all over all the time. I bounced between specialists, had every test you can think of, and left each appointment with more questions than answers. Then one night, while scrolling through Twitter, or what used to be called Twitter, as one does when desperate for distraction, I came across a lab at the Medical University of South Carolina researching the mechanisms of hypermobile Ehlers-Danlos syndrome, also known as HEDS, a genetic connective tissue disorder. The collection of symptoms I was reading about sounded suspiciously like what I was living through. Not only was the team in Charleston conducting research, but they were looking for interns studying STEM who had HEDS. The collection of symptoms I was reading about sounded, oh gosh, I already told you that part. Most primary care physicians are unfamiliar with HEDS. The average delay between symptom onset and diagnosis happens to be over 10 years. This is what a lot of people in the community refer to as a diagnostic odyssey, a long journey from symptom onset to diagnosis. On top of that, HEDS is the only subtype out of 14 Ehlers-Danlos syndromes that does not have testing available for known causal genes. That means it is both an invisible disability and an unsolved puzzle for the medical community. I had no diagnosis at the time that I found the internship, but I reached out anyways. I asked if I could still apply, even though my condition had not been confirmed. After I interviewed, it took them just 7 minutes to offer me the position. That summer, I moved to Charleston. I spent my days doing research and learning about HEDS, and through the incredible mentors there, I finally got my diagnosis confirmed. At the end of the summer, my mentor and the team sat me down for a meeting, not to discuss the data that I was working with, but to convince me to pursue a PhD, to consider a career in research. After a whole year with no direction, no thoughts of anything past the day in front of me, I was suddenly imagining a future in science. I had previously intended to pursue genetic counseling, but the proximity of research to groundbreaking developments in the field drew me in and captivated my mind. Back at Clemson, I switched my focus to research. I joined a canine genetics lab, comparing disease etiology in dogs to what was known in humans. I even got to start my own independent project on miniature American Shepherds, met and fell in love with Eloise, and she is now my greatest joy. When the time came to apply to graduate schools, I was advised against disclosing my disability until after I received offers. It might be seen as a hindrance toward my degree progress and ability to produce research for a university. I decided to write about it anyways in my admissions essays because I didn't want to attend a program with a culture that was not going to support disabled students. I leaned into my story. I talked about my diagnosis, my lived experience, and my newfound passion for accessible research. I wasn't trying to hide my disability. I was reframing it as a strength. And I guess it worked. I received offers of both admissions and competitive fellowships and got to share my experience as a patient scientist. I think that the programs that accepted me recognized that having experienced the patient side of genetics, I can provide valuable perspective and enhanced motivation to clinical research and patient care. Patients are often an overlooked resource for important scientific questions, and patient outreach can lay the groundwork for developing treatments and interventions that target the most troubling issues. MUSC's HEDS research program and the internship I participated in have led to the first candidate gene discovery for HEDS, with almost every initiative and scientific publication driven by a patient scientist. We need more disabled representation in both genetics and biomedicine to provide an empathetic lens to our research and connect our goals back to those we hope to serve. By including patients and disabled researchers in the research that benefits them, we can ensure the impact of our work and learn from the perspectives of those it supports. Diverse perspectives in research broaden our minds, enhance our critical thinking, and keep moving us forward, because inclusive science means better science for everyone. Thank you.
Dr. Barbara Marston is an infectious diseases physician who retired from the CDC in 2022 after a 28-year federal career primarily focused on international health. She had leadership roles in emergency responses, Ebola in West Africa, and the international component of the COVID response. Since retiring, she's been traveling and supporting protection of endangered amphibians and native plants. She's the co-founder and the coordinator of a CDC advocacy group, CDC Alumni and Friends. Tonight, Dr. Marston is sharing a story of her work and a slow-building realization of how help with global health builds goodwill on the ground in other countries. Dr. Marston.
That's some tough acts to follow. So I'll add my thanks to Healthbeat and the Georgia Health Initiative, and also just admit that the story that I'm going to tell is a story that's shared by many others. It's related to early work in international HIV, and I was involved at the very beginning, but there are many people, thousands of people, including some in this room, that have been involved in carrying on that work, and just to say that it's a shared story. So as a teenager, I had been aware of the investigative work done by CDC during the 1976 Legionnaire's disease outbreak in Philadelphia. But it was during my medical residency that I really began to understand public health. I saw that in the response to infections in our hospitals, to rising cases of measles, and the investigation of mad cow disease. And while I very much enjoyed working with one patient at a time, public health offered the chance to improve the health of entire populations. And I wanted to give that a try too. So after residency, I joined CDC's Epidemic Intelligence Service, or EIS, sometimes known as the Disease Detectives. I found myself in Pakistan evaluating the validity of survey questions on immunization rates, and later on rooftops in Los Angeles, sampling water from cooling towers for the now well-known Legionella bacteria. After EIS, I returned to clinical medicine to complete my infectious disease specialty training and was immersed in the rapidly evolving world of HIV treatment. A few years later, I moved with my family to Kisumu in western Kenya. My husband would be directing CDC's research field station there. I was the trailing spouse, having spent the previous few years continuing to provide some HIV care, but also focused on our very young children. In Kenya, I was initially planning to do malaria research, but it was immediately apparent that it would make much more sense for me to apply my experience with HIV. And when we arrived in 2001, 1 in 4 adults in Kisumu had HIV. Coffin makers were thriving. Almost all hospitalized adults were HIV positive. And CDC's research programs had to hire 125% of needed field staff because so many people were dying on the job. Against that devastating backdrop, the world was starting to realize that HIV services needed to be offered in some of the hardest hit parts of the world. The initial focus of these services was on testing and on prevention through counseling and by providing limited treatment to pregnant women to keep babies from acquiring HIV. But the counselors at the testing sites were very frustrated. If someone tested negative, they could share advice about how to stay negative. But for the many people that tested positive, there was very little to offer. So I had access to very limited resources at that point, but there was clear evidence that an inexpensive antibiotic, trimethoprim sulfamethoxazole, you might have heard of it as Bactrim or Septrin, or you might know it as TMP sulfa, could help could protect people from many of the infections that developed in people with HIV because of their weakened immunity. So we established some clinics and provided that antibiotic. It didn't control the HIV, but it did dramatically improve our patients' health while we looked for a way to access definitive treatment, the antiretroviral drugs, or ARVs. I'd heard of a grant opportunity from Columbia University School of Public Health, and 3 friends and colleagues, one working on prevention of mother-to-child transmission, one supporting a community program, and one from the provincial hospital, and I put together an application. That grant provided drugs for a very slim subset of our patients, women who were diagnosed during pregnancy. And we got a few individual donors and church groups to help us with drugs for a few more of our patients. It was very slow progress, but it helped prepare us for what was coming, the resources that would be coming, and they did come. So in 2002, the Global Fund for AIDS, TB, and malaria was established. And in 2003, President Bush announced that the U.S. would support HIV treatment through his signature program, the President's Emergency Plan for AIDS Relief, or PEPFAR. Knowing that the treatment drugs were on the way, we continued to expand. My Ministry of Health colleagues and I went to scores of hospitals and health centers offering to help establish HIV treatment clinics. And usually the healthcare staff would say they wanted a clinic, but they didn't have the resources or expertise. What a privilege for me to be able to say we can offer both. My colleague at USAID and I found an organization that could procure drugs, the Mission for Essential Drugs and Supplies. We just had to move the money. The contracting office put us in a bind. At first, they moved very slowly. Then suddenly they gave us an ultimatum. They would finalize the contract, but only if we could secure signatures from 6 board members scattered all over Kenya over a weekend. So my colleague John took Eastern Kenya, and I took the West. With the CDC driver, off we went. I had the easier job because all the board members were bishops, but 2 of mine were Anglican, meaning they had wives. Made them easier to find, and the wives helped us track down their husbands. So cell phone coverage was limited, and we chased several false leads down Kenya's rough roads. But by the end of the weekend, John and I had both secured our share of the needed signatures. To people who'd been asking, when are the drugs coming, I could soon say, they are here. I had lived through the transformation of HIV in the US from a death sentence to a manageable chronic illness, and now I had the privilege of witnessing that transformation again on a massive scale. By the time my family returned to the US in 2005, 65,000 people in Kenya were on treatment, and that's a tiny fraction of the number who have since initiated care, but that early period was transformative. The coffin makers returned to building furniture, ambulances stopped serving as full-time hearses, and weekends, once dominated by funerals, were once again times for dance parties and weddings. The effects of establishing HIV programs began to ripple outward, strengthening the health system. Trusted relationships with our Ministry of Health colleagues deepened, and that trust meant we were often the first called when new threats emerged, whether it was anthrax or a hemorrhagic fever, and we were able to assist with controlling those threats, protecting both Kenyans and people in the US. Taxi drivers in Kenya are a great source of wisdom. During my frequent trips to Nairobi, I often asked for their perspectives, and every one of them had been touched by HIV through a sibling, a spouse, or their own diagnosis. Many had faced initial reluctance to get tested or seek treatment, but in overcoming stigma and barriers, they found a return to normalcy and a deep gratitude to the Global Fund, the World Health Organization, and the United States So maybe not an aha moment, but a quiet recognition that focused programs can build immense goodwill. And I had the great privilege of being a small part of that.
Dr. Barbara Marston, thank you so much. Our final story comes from Dr. Kimby Hagen. Dr. Kimby Hagen is the founding director of 2 international science-focused dinner clubs. Although she's been a faculty member in the Department of Behavioral, Social and Health Education Sciences at the Rollins School of Public Health at Emory since 1998, her total lived experience serving as a public health educator turns out to have predated by several years her awareness that public health education, or even just public health, existed. Tonight, she shares the story about what her role in public health has come to mean to her and how she supports all of you. Our final story, Dr. Kimby Hagen.
My aha moment in public health, or the echo from it, is the reason that I was late getting here this evening. For context, back in 1981, Dr. Jim Curran directed a task force to look at the very first cases of the disease that Dr. Marston was just talking about, AIDS. I joined the field 5 years later as an HIV/AIDS medical and community educator, and 12 years after that, in 1998, Dr. Curran recruited me from the Emory School of Medicine to the Rollins School of Public Health, where he was now serving as dean, to start a CFAR, Center for AIDS Research at Emory. At one of our very first organizational meetings with shareholders around the campus, somebody suggested that the CFAR and the Emory Vaccine Center collaborate on an evening seminar series that would help raise both of our profiles on campus. Well, I thought that was a great idea, and I kind of blurted out like, you know, and we could serve food, and we'll call it the Vaccine Dinner Club. Well, their reaction was very much like yours just now, but when Dr. Curran handed the initiative to me to design and to organize and to run, that's exactly what I did. Having heard that as many as 30 or 40 scientists would attend a vaccine talk around HIV, I reserved an appropriately sized room for the first meeting and sent out emails to a couple of my colleagues to ask for help in advertising the meeting. In that email, which I begged people to treat like a chain letter, I said that if you wanted to come to our first meeting, we would have a wine and cheese reception, followed by a science talk from Vaccine Center Director Rafi Ahmed, followed by a casual buffet dinner. Well, the responses to that email started trickling and then just flooding in, which should not have been a surprise to me because this was a moment in history when you could not even get a cup of coffee at a federally funded meeting. And I was offering wine, cheese, and dinner. So, as many of you know, the CDC is a sort of a separate nation state on the Emory campus. And I think almost everybody at the CDC came to that first meeting. By the time that it started, I had over 300 registrations for the meeting. And on the day, to this day, I swear I felt the ground just sort of gently vibrating beneath my feet as wave after wave of CDC employees were thundering down Clifton Road, apparently at a dead run, in the direction of food and drink-enabled science. And that was pretty cool, but my elation turned to panic when the milling crowd figured out that somebody had forgotten that in order to drink wine, you have to be able to get out of the bottle first. But fortunately, The Vaccine Dinner Club membership has self-selected from the very beginning for resourcefulness, and it turns out a surprising number of people carry corkscrews around in their pockets and purses. So, in very short order, a informal bucket brigade of scientists led by biostatistics luminary Bets Halloran set up to uncrate, open, pour, and distribute over 300 glasses of wine. The rest of the evening went really, really well, and I think that that set the stage for the Vaccine Dinner Club being seen as a club, not a seminar series. So you would think, of course, that that would be my aha moment, but no. And in fact, it still wasn't my aha moment 21 years and almost 200 programs later when the pandemic happened and the Vaccine Dinner Club had to go online. I still remember with vivid clarity walking up to the podium on March the 4th, 2020, to open a program called COVID-19, What We Know, What We Suspect, What We Fear. The presenter was Dr. Jay Butler, who was the Associate Director for Infectious Diseases at the CDC, and the program was well attended. In those days, it was our average attendance at a monthly meeting was 200. But I don't know how many people were there that night, and I really don't, because in order to ensure plausible deniability with the fire marshal, I stopped counting at 550. But let me put it this way, it was a 2-tier auditorium, and it was standing room only. And when I walked behind the podium and I looked out at this sea of faces, I stopped ringing the cowbell we opened every meeting with, and I just blurted out, Dr. Butler's talk is going to include an analysis of super spreader events. And speaking of super spreader events, I would love it if everybody here could behave responsibly and hold your breath for the next 60 minutes. So you would again think that that would have been my aha moment, but actually it turned out to happen down the road when the Vaccine Dinner Club had reformed itself as an online Zoom event. And much to my puzzlement, it just kept growing. I thought that the VDC was going to implode in the absence of, I don't know, free wine, but no, instead, the membership requests for the membership and meeting registrations were exploding during the pandemic. And then, one day, I figured out why. I was sitting at my desk and I was reading through the comments on a registration form for one of the upcoming meetings, and I won't forget what this said. It just said, thank you, Kimby, for keeping the VDC going. My job is to increase COVID vaccine uptake in a part of the country that thinks COVID-19 is a hoax. And I live for these monthly opportunities to just relax, if only online, with my tribe, the people who get it. The Vaccine Dinner Club makes me feel less alone. And that's when I realized what it was that this club did, what I was doing, is that in a world that was increasingly making the trashing of public health and the trashing of public health professionals into a full-time job, the Vaccine Dinner Club had gone beyond being a place where you could access cool science to being a place where you could access a safe space, where you could come, hang out with your tribe of the people who get it, and feel seen, feel heard, and feel supported. That crystallization redoubled a few years later when I paused the Vaccine Dinner Club for the entirety of the 2024-25 season. And then when I restarted it this past September, I got literally hundreds of thank you messages from people. And this is people all around the world, because one thing I should have mentioned is that while the number of registrations and meetings were growing, I got to the point where I had to start each meeting with a slide showing the number of countries that were growing and growing and growing. People all around the world were coming in because we're all facing the same thing. And so, because of that, when this past summer the two major sponsors of the Vaccine Dinner Club told me that they wanted to reduce the meetings from monthly to quarterly, and they wanted to revert them to in-person only, which would make them only accessible to people in Atlanta, I felt like I needed to do something. Because now I get it. I'm a public health professional, but my public is you. I do what I do so that you can do what you do. And I did not want that to end. I didn't want that safe space to go away. So my solution, let's start a second dinner club. With the support of the Rollins School of Public Health, I started another club that only meets in the months when the Vaccine Dinner Club is not meeting, now that it's just quarterly, and is Zoom for everyone. It's worked. We currently have, when I looked before this evening, 6,711 members, which is not bad for a club that didn't exist 2 months ago, and is 1,300 members more than the Vaccine Dinner Club took 27 years to accrue. Wow. Which I think speaks to the need for a place for public health professionals to be in a space where they can be seen, they can be feel, and they can be appreciated. The first meeting last month was on public health crisis, what it means for America, public health chaos, what it means for America. And it starred Dimitri Descalasis, Deborah Howery, and Dan Jernigan, the three senior scientists from the CDC who resigned after the director was fired. Our meeting this evening starred Dr. Hotez, Peter Hotez, and was about anti-science. So we are continuing to find new ways to try to reach people who do public health. I should mention, 2,600 people attended the first meeting. 100 of those people registered for the meeting retroactively so they could hear the meeting recording. And I will put out a QR code if you want to retroactively register and hear Dr. Descalasis, Dr. Howery, Dr. Jernigan talk about what went down at the CDC and the downstream effects of it. But I also want to talk a little bit about anti-science. Before I end this evening, I want to read something if I can find it. Here it is. What I'm going to read you originally came from an email that I included in this month's advertisement of our as yet unnamed dinner club. That's the official title. I outsourced the naming of the group and we're still trying to do it, but this was for the as yet unnamed dinner club. And it came from conversations that I've had with Vaccine Dinner Club and VDC and UDC members who've reached out to me to talk about how distraught they are, how much I am, how much we all are over the deliberate big damage that's being done to public health these days. And this is what I wrote. This is what I want to end with. I keep reminding myself that perhaps the only advantage to being as old as I am is that I've lived a long time, including growing up in the Jim Crow South, which means that I have real-time memories of cross burnings, segregated schools, whites-only everything, and the Tuskegee study, which also means that I know from my own lived experience that we as a country are fully capable of righting great wrongs that are inflicted on us by our government because we have done so before. There is precedent for that in my lifetime. So I have to believe that we will get through this because we can get through this because we have gotten through worse before and come out on the other side. Thank you.
Two phrases from so many stories tonight stand out for me from this evening. The first is the phrase, the patient scientist. Clearly a scientist who knows and can tell the story of the patient. And the second phrase that struck me was, I am because we are. It's a simple formulation, but it's a powerful one. And if you doubt that, imagine its opposite. We are because I am. Can you imagine anyone who would say that? In public health, we don't. I am because we are. Thank you for your stories. Thank you for coming out tonight and supporting your friends and neighbors in public health. We'll be posting these stories, along with many others, online at Healthbeat, and we'll be sharing the videos, and we hope you will all amplify those to your networks as well. Please tag Healthbeat in your social media posts about tonight's event. In the next day or two, we'll be sending out a survey about this event, and we'd appreciate your feedback on whether we should do it again, and other events you'd like to see to support Atlanta's public health community. Charlene, any final thoughts?
Thank you.
Thank you and good night.